The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss Beyond the Standard of Care, the role of clinical trials. My name is Antoinette Tu, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speakers today, Dr. Ryan Merrell and Dr. Julian Bailes. Dr. Merrell is an attending neurologist and medical director of neuro-oncology at North Shore University Health System in Evanston, Illinois. He is a clinical assistant professor at the University of Chicago. He received his medical degree from the University of Alabama School of Medicine in Birmingham, Alabama, and completed his residency in neurology at Mayo Clinic, Rochester. He then completed a fellowship in neuro-oncology at Massachusetts General Hospital Cancer Center, Dana-Farber Cancer Institute. His primary interests are treatments of primary brain tumors and meningiomas. Dr. Julian Bailes is a nationally recognized Chicago neurosurgeon with special emphasis on brain tumors and the impact of brain injury on brain function. Dr. Bailes and the North Shore Neurological Institution team are among the first in the country to use emerging technology to treat brain tumors, including Visualase MRI laser-guided therapy and NICO BrainPath. North Shore Neurological Institute has become the first in the state and only a handful in the country to utilize synaptive servo, a robotic technology that improves access, precision, and visualization. Thank you for joining us, Dr. Merrell and Dr. Bailes. You may now begin your presentation.
Good afternoon. This is Dr. Ryan Merrell, and I'd like to thank the ABTA for inviting us, and it's an honor to be with you today. These are just some disclosures. I have had some consulting work with the AbbVie company. Other than that, I have no other disclosures. So just an overview of what I'll be talking about today. I want to talk about what is a clinical trial, what are the phases of different types of clinical trials, why or why not would you want to do a clinical trial, where and how do you find a clinical trial that's right for you, how do you qualify, so what's the eligibility, different types of clinical trials, and then as a bridge to what Dr. Bailes is going to be speaking about, what is the connection with clinical trials and different types of novel brain tumor surgery. So some of the key terms I'm going to be using, a clinical trial is basically a study designed to test a new treatment that previously has been shown to have benefit in brain tumor models. Now this could be a model such as a mouse model, or it could be an early phase of a trial that was tested first in humans, but something that has scientific merit and safety in order to be tested in a brain tumor patient. The phases of the clinical trial, these range from 1 to 3, basically 1 being the earliest phase and 3 being the final phase that would be needed to achieve FDA approval for a drug or treatment. Inclusion and exclusion criteria are the parameters needed to enroll in a trial, kind of like a checklist of what you need and what you cannot have in order to do a clinical trial. And when we use the term placebo, this is somewhat misleading because I think most patients think of like a sugar pill, but that's not the case in clinical trials because it would not be ethical to give a patient a sham treatment or a sugar pill. So usually a placebo arm is going to be an actual drug that you would receive if you were randomized to that arm of the trial. So what are clinical trials? Our goal as neuro-oncologists is to find better treatments for tumors. We desperately need better treatments for all different kinds of brain tumors and spine tumors. And so one of the questions we often are asked is, am I going to be a guinea pig? I think when patients think of clinical trials, they think of a study where we might just be trying to test out a treatment and to see how a patient would react to that, but that's really not the case because all these trials are very well thought out. Years go into the design of these trials, and we're really trying to find as quickly and safely as possible better treatments for these tumors. So if you participate in a trial, the vast majority of clinical trials are going to be emphasizing a treatment that will add benefit to the standard treatment that you would be receiving. It's important to know that all research is conducted under strict safety guidelines. So in the United States, we have very strict criteria for the safety testing of these treatments. And all of us are subject to institutional review boards, which really are designed to make sure that we provide safe treatments and are not and are completely abiding by the rules that we need to follow. These trials are conducted with multiple sites, often is the case, so we call that consortia. So we would have anywhere from 20 to 50 different institutions in the United States and oftentimes even in Europe that are participating in these same trials. And all the current standard treatments for brain tumors originally had to be tested in the context of a clinical trial. So for example, like the drug temozolomide, which is widely used in treating brain tumors, originally had to go through the same testing that we're talking about for these clinical trials. So trials can be in different stages. So for example, the example I'm going to use often in this talk is glioblastoma because it is one of the more common tumors that we have clinical trials for. So if you have a glioblastoma, you may be new in your diagnosis, and that would be a time when you could have the possibility of doing a clinical trial. Or if the tumor grows back at some stage, then you could be a candidate. And trials are designed for these different stages of treatment. So what are exactly the three phases of clinical trials? So phase one is really a dose-finding study. It's really testing the safety of a drug. So it's very different than phase 2 and 3. And many times a drug that's new and has a lot of promise, it's important to know like what are the side effects that are going to be experienced that may not have been elucidated through like a mouse model. So in that sense, a phase 1 study is a good study to participate in because it is a promising drug. And oftentimes, it's more than just finding the right dose. It may be that that drug is really impactful and you may have a great benefit from participating in a phase 1 study. The other thing about these studies is they have looser criteria, so the eligibility is easier to enroll in often in phase 1 studies. Phase 2 is basically you have the dose established and then you're testing it out. Oftentimes, these trials are randomized with a placebo arm. And then phase 3, as I mentioned earlier, is really the final stage where a drug has passed enough benefit in the phase 2 to go into phase 3, and then hopefully would be show enough benefit to be FDA approved. So we have randomized placebo trials, and then we have open label trials. And open label means that all the patients will get the study drug no matter what. So there's no mystery as to whether you might be on the placebo arm. When we talk about double blind, that's another term you may see, and all that means is that the investigators, the doctors, and the patients do not know whether or not the patient is receiving the study drug or the placebo arm. So in glioblastoma, newly diagnosed trials are adding on treatments to the standard treatment. This is a question that we often get. So, we are going to give radiation and temozolomide no matter what, and then we are going to add on potentially another drug to that treatment. As I said earlier, there's no such thing as a placebo. There's no sugar pills in our trials. And one question we often are asked is, are these covered by insurance? Well, whoever sponsors the study, whether that be a consortia of multiple institutions through like the National Cancer Institute or a pharmaceutical company, much of that cost is going to be covered through that mechanism. All the standard of care things like MRI scans and doctor visits are going to be covered by insurance. There always is a possibility that there could be an out-of-pocket expense, and that's something that we have to inform our patients about. But for the most part, these are covered by insurance. So what are the pros and cons of doing a clinical trial? Well, obviously, if you have a treatment that really adds benefit to the standard treatment, that's a big deal, and that's what we're all looking for in this field is better treatment. You will receive more care, so there'll be more visits than the standard care that you would normally get. And you can think of it as altruistic in the sense that you're contributing to science, so you're participating with a number of other patients in adding knowledge to the field. Now, the more care can also be considered a con because you will be required to come to the doctor more often, and if you don't live close to the doctor, you may be required to travel more. This especially is true for out-of-state travel, which we'll talk about later. What about side effects? You know, all these treatments have potential side effects, and some of these could be unpleasant. And then there's unpredictability. So even if we have a sense of what are the common side effects that a treatment could give, there's always going to be something unpredictable and potentially life-threatening that could occur as a result of one of these treatments. Where do you find clinical trials? Talking with your neuro-oncologist or your medical oncologist is important because that person can really guide you in terms of knowledge of what's available in your city and in your region. So I think that's the best starting point. The ABTA has a great tool called ABTA Trial Connect, which I'm going to display for you in an upcoming slide, that helps you to search clinical trials. Clinicaltrials.gov is a long-standing website that has a pretty good search engine, and I recommend that site, but I'll show you that there's some difficulty in navigating that. And then whether to stay in town or travel out of state, this is a common question that I receive. You know, I think that for the most part, I recommend that you stay close to your home because, you know, for many patients, there are good institutions nearby where you can have access to good clinical trials without having to travel out of state. And the thing about it is that if you were to do a clinical trial in your hometown or do a clinical trial 500 miles away, no one can really say that their clinical trial is any better than another person's. So that's one of the things that we often discuss with patients. But if there is a situation where there's a clinical trial that one of my patients really wants to do 500 miles away, I will do everything I can to support them in being connected to that trial. So here's an example of the ABTA Connect website. You type in some search terms. There's a list which I wasn't able to display in this slide. And what I did here is I typed in glioblastoma, and then I typed in a number of other terms like newly diagnosed. And then it gives me this nice menu to look at of all the different trials that are available. And I can search by location, and I can put in other types of criteria that narrow things down. So this is a really nice tool. In contrast to clinicaltrials.gov, which I still think is a good website, this is a little bit cumbersome because, as you can see, I put in the term glioblastoma and I have 1,147 studies. I mean, who could possibly navigate all these studies? So if you do some refining and I put in glioblastoma vaccine, I get down to 74. So you can kind of refine your searches. I think these are two good sites. There are other sites out there. And I think this is a helpful tool for patients. So what does it mean by eligibility criteria? These are some of the main things that clinical trials are going to look at. So age. Unfortunately, some of the clinical trials will cut off by age. So many of them will say you have to be younger than 70, sometimes 75. So that can be an important thing to look at. Performance status means what is your level of fitness? So how neurologically well are you? You know, if you have the inability to walk, for example, that's a significant impairment that may disqualify you from doing certain types of clinical trials. The number of previous treatments is important. You know, when you're looking at a recurrent trial for glioblastoma, for example, many of the trials will say that you can only have 2 prior treatments to enroll in them. So that's an important thing to look at. Surgery is becoming increasingly important, especially in some of the immunotherapy trials. So if you have a recurrent glioblastoma, for example, some of these trials will say that you have to have an 80% or more ability to remove the tumor at that time. And so for some patients, that's not practical because they may have a tumor that's not able to be operated on to that extent. And then molecular markers is important. So these are increasingly important. These are things that you can test for in the tumor, and some of these tests are required in order to enroll in certain types of clinical trials. And I'll tell you about that in an upcoming slide. So no one knows what the best trial is. That's really important. The location of the trial really can influence your decision on which one to do, whether in your own hometown or far away. Some patients really don't like the idea of being randomized to a placebo. So that's an important consideration. So looking for the open label trials that I mentioned earlier. You know, the side effects of a treatment, let's say it comes down to a decision between 2 or 3 clinical trials and you're looking at these and you really don't know and no one really knows which one is better. Well, maybe one of the trials has a really unpleasant side effect that you just don't want to have the possibility of experiencing. Well, that certainly could influence your decision about which trial to choose. And then the schedule of the trial. You know, how often are the visits? Are they every 2 weeks? Are they every month? Are they every other month? You know, that's an important consideration for traveling. And then whether or not to do surgery. Some patients can be very weary of undergoing a second surgery or undergoing a surgery that could possibly give them deficits. So that's an important thing to think about. As 2 different types of broad categories of clinical trials I'd like to talk about are targeted therapies and immunotherapies. In no way does this represent the entire field of neuro-oncology research, but these are 2 kind of very big categories and certainly the latest and greatest of what's going on right now. So what are targeted therapies? This is a cartoon here that represents growth pathways in a brain tumor, and let's just say it's glioblastoma. These are pathways on the surface of the tumor cell that are needed to be activated in order to drive growth of the tumor. So much of the research over the past 10 to 20 years has focused on how do you interrupt these pathways in order to slow the growth or stop the growth of the tumor. Many clinical trials have been done over the past 10 to 15 years looking at all these different mechanisms of slowing growth. A couple of them that I mentioned here are, for example, vascular endothelial growth factor. These are some of the angiogenesis inhibitors, such as bevacizumab, also known as Avastin. Epidermal growth factor continues to be an important pathway because this pathway depicted here on this side of the screen is a pathway that is often overexpressed in glioblastoma, and so there's been great efforts to try to target it. What about immunotherapies? Very different in terms of what we're doing here. We're trying to engineer the immune system to attack the tumor. We have known for a long time that in brain tumors, much like in other kinds of tumors in the body, there is a derangement of the immune system. That's one of the ways that these tumors grow in the first place, is that our own immune system is not able to fight them off. Many of these immunotherapies are delivered through a vaccine, which is somewhat of a misleading term because I think when we think of vaccines, we think of like, you know, getting a shot for shingles. You know, the whole idea here is that you're trying to trigger the immune system to mount an attack against the tumor. And there are many different ways of approaching this. So this is a cartoon that kind of demonstrates how the immune system becomes deranged. So normally we have a population of lymphocytes which are surveying for foreign invaders, including tumor cells. And the smart tumor will actually send signals out that will downregulate this process and put it into this T regulator mode. And there are many recent breakthroughs that have looked at how do you turn off these signals so that you can turn back on the normal lymphocyte response. So what are some very broad categories of these different types of immunotherapies? We have peptide-based vaccines. Example is rindopepimut. Dendritic cell vaccines such as ICT-107. Tumor lysates, where you actually take the tumor and you expose the broken down tumor, and that's your DC-Vax. CAR T cells, another very interesting pathway where you engineer lymphocytes to respond to molecules on the surface of the tumor. Viral vectors such as poliovirus and measles virus, and then gene therapies like TOCA or adenovirus, which I'll talk about in an upcoming slide. So there are different types of clinical trials in different categories of tumors. So in high-grade glioma, there's several different types of ongoing clinical trials. In no way is this representing all the clinical trials out there, but these are just different categories. So we have dendritic cell vaccines like ICT-107. We have checkmate inhibitors like nivolumab. We have heat shock protein inhibitors. We have other types of checkpoint inhibitors that target this PD-1, PD-L1 pathway, which you may have heard of. We have ABT414, which is an EGFR targeted drug. And then TOCA5 is one of these viral gene engineered therapies. And then in other types of tumors, low-grade glioma. So low-grade glioma has sort of been a neglected entity for a long time. Now there's been increasing emphasis on developing clinical trials for these tumors. The most representative right now is a trial called the AG120 trial, which I'll talk to you about in an upcoming slide. And then a recent trial using an mTOR inhibitor, everolimus, which is a way of targeting one of those pathways on the cartoon I showed you earlier. And what about meningioma? Meningioma traditionally has had the least amount of clinical trials, but there are some meningiomas that can be very aggressive, and there's no defined chemotherapy for meningiomas. There's a current clinical trial through the Alliance Consortium that's targeting the smoothened and AKT pathway that is open through that consortium. So just to give an example of a couple of clinical trials, ABT414 is a targeted therapy that interacts with the EGFR receptor. It actually introduces a toxin after this antibody binds to this receptor. And this is a little cartoon to show you how this works. So this antibody binds, then it releases a toxin, and then ultimately that interacts with the DNA of the tumor to lead to death of the tumor cell. The TOCA511 and TOCA-FC is part of what's called the TOCA5 trial in recurrent high-grade glioma, including anaplastic astrocytoma and glioblastoma. This is an interesting treatment that actually delivers a retrovirus which will cleave a drug given orally into a potent anti-cancer drug called 5-FU. Now 5-FU is nothing new. This has been around for a long time. The whole idea here is that if you give 5-FU intravenously, it will not get into the brain. And this is a way of circumventing the blood-brain barrier by giving a prodrug, which is called the TOCA-FC, which eventually will become 5-FU by this gene that's delivered at the time of surgery. This is an example of a trial that requires surgery in order to participate because the viral vector is actually introduced at the time of the surgery. The AG120 trial, which I mentioned earlier, this is for tumors that have IDH1 mutation. IDH1 mutation is seen much more so in lower grade gliomas. We know that this is a deranged metabolic pathway, so if you have the mutation, ordinarily with the Krebs cycle, which some of you may know about from biochemistry, this actually leads to a downstream product called 2-HG, which normally is not produced by the Krebs cycle. And this drug actually interferes with this mutation, and ultimately that will decrease growth of the tumor cell. So very interesting thing that we have learned as a result of uncovering this IDH1 mutation, which is the most recent molecular mutation that has become known in gliomas. So now I'd like to introduce Dr. Julian Bailes, who will talk more about novel neurosurgical techniques. And this is very important nowadays because of the link between surgery and clinical trials. Dr. Bailes and I work together closely here at North Shore. He's a wonderful colleague, and I'm happy to have him here with me today.
Thank you, Dr. Merrell. Great to be here and tell you a little bit about what we do from the surgery perspective. And for brain tumors, ordinarily neuro-oncology treatment and the clinical trials you heard about go hand in hand with the first step in most people's treatment, which is to take the tumor out, analyze it in the lab, find out what tissue type it is, what grade it is, and how we approach it through standard treatments or emerging drug treatments, as you've heard a lot about today. I have no disclosures or anything else to report related to this presentation. So the concept of minimally invasive brain surgery has really taken off in the last few years, and as you'll see, a lot of it has to do with the new instruments we have, the new technologies that we bring to bear at the point of disease of the tumor. And also, a big part of surgery has always been and remains today maximum removal of the tumor, because that's consistently been shown to be one of the best prognostic factors you can have. So certainly we want to be safe in that process, but allowing more tumor, removing more tumor allows a better diagnostic accuracy in sampling all the tissue that you can find for the neuropathologist and us to look at. And it is needed now for molecular studies, really looking at some of the more genetic traits, which gives us insights to tumor treatment. Maximal surgical treatment is a requirement for entry into many clinical trials. For example, some trials with new and emerging treatments require 80 to 90% removal of the tumor, so maximum debulking or reduction of the amount of cells that are there. New and emerging novel neurosurgical techniques allow for maximum surgical removal and often with less harm to the patient because they're focused. And I'll mention later that inserting a laser fiber to ablate or destroy the tumor is a new technology that we have here at North Shore University Health System, and we're very excited about the potential for that. Now, this is not me operating. This is our forefathers in neurosurgery, and as you can see, they were doing the best they could with the tools of that time. However, they worked through larger openings, and the big problem was getting light into a surgical incision or an opening in through the skull into the brain, and not only light but magnification. So there have been a lot of advances just in our lifetime that has transitioned this from what you see in the bottom right picture to what we have today. This is sort of how the operating room now looks. It's full of technology and replete with high-tech capabilities and bringing many new instrumentation and techniques to bear at the point of the surgery. You know, it's said by the neuroscientists that our brain contains over 100 billion neurons or nerve cells, probably 5 times that many supporting cells, the astrocytes. And if you take all the connecting fibers and you see the major pathways here that we have to avoid and navigate around, that if you put all these connecting fibers together, it would equal 100,000 miles. So it wouldn't go from the East Coast of the U.S. to the West Coast. It would be about 30 times that distance. So it's a lot packed in, and this is the most complicated structure on the face of the earth, and one that we're privileged to try to help patients as they deal with different lesions or problems within the brain. But these are the areas that we have to be aware of. These are the major fiber pathways that are taking motor, sensory, visual, speech, hearing, and other key components of brain function. So this is a big part of what we think about and do. Here's an example of a malignant brain tumor, and one that comes to the surface. You can see it's, in this case, on the sort of the bottom right, the irregular white enhancing lesion there. It's got challenges in terms of its geometry, its irregular shape, and its blood supply. Here's another one, the splenium part of the corpus callosum, the major fiber bundles between the two halves of the brain. Deep and also very irregular and very vascular. So these are some of the challenging lesions that we take on. One of the new technologies that I've been very enthusiastic and have had a lot of experience with is the NICO 6 pillars approach. And what this does really is that it shows you that there are new ways that we look at taking out tumors based on this technology. The technology involves fiber tracking, knowing where the fiber tracks are. It involves navigation, which is like a GPS system, so that we have cameras in the ceiling of the operating room and we know where we are as we course through the brain. Special optics, magnification, and light. You see on the bottom left, this is a port, a dime-sized port or tube, and then that inner blue part is removed, and it's placed in a navigated manner, avoiding the major areas of concern, and placing it into the tumor. The middle bottom picture is the new instruments that we have to resect or remove tumors now. As you can see here, this is called a Myriad, one of the many devices that we have to take out tumors. I'm often asked by patients, Doc, how are you going to actually get that out? And then, of course, on the bottom right, we have great hope, and there's promise for, after removing the tissue, to really analyze it, and as one day we'll be able to do more and more by the analysis of what we removed. This is the so-called 6-pillar. And here's a picture of me operating, and you can see in the top left view here, this is fiber tracking. Here are the green fibers that control motor control. On this side, you see the white tumor, and you see how those fiber tracks are thinned or attenuated and displaced lateral. So our approach here would be between the two halves of the brain, right in here, and that would be a safe approach, knowing that the fibers are displaced to the outside. And here's how we operate here. You see the optics and the magnification. Here's an intraoperative ultrasound as we go through. Here's the lesion in the brain, and here's how we look on our monitor, sort of in our surgical cockpit. And this is an artist drawing showing that port, that dime-sized tube that we can place in there. We place that in the natural folds of the brain, the sulci, so we don't have to remove part of the brain. We can go through the natural folds and get to deep lesions inside. The human brain is the last organ in the human body to be conquered for working on the inside aspect of it. On the right, you see sort of the surgeon's view. You see the normal white matter of the brain here, and this is the hole where the bad tumor was resected, and we save all that tissue for further analysis and diagnosis. Here's another example here showing how we look at a tumor and how we also can analyze the different fiber tracts around it, and that diagram I showed you with all the important fiber tracts, this is how we overlay this to help us do surgery deep in the brain safely. Another example here, this is showing not only here's the tumor here, but here's the motor pathways, the sensory pathways, and here's the speech pathways here with the tumor here. So this is called the arcuate fasciculus, and here's the motor fibers coming down, and so that helps us with something called functional MRI, where we can analyze where different parts of the function of the brain is, and we overlay that all in our surgical planning. Here's an example of Dr. Merrell mentioned a meningioma. Here's one that's deep in the brain inside the cavity, the ventricle, and the tube was placed right in here, and you can see postoperatively after the tumor's been removed. So we have published our first 20 cases that we've done using this technique, and you see we have a strong commitment here at North Shore to not only patient care, but the academic side and trying to really understand what we are seeing and what makes a difference for patients. Here's another tumor with the patient in the back of the brain, causing visual problem, and then once that was removed, as you can see it here, is displacing his visual fibers, which are here, the normal side over here, and then after the tumor is removed, those fibers then get restored. Another example here, here's the tumor, here's the normal fiber pathways. You don't see them because they're thinned out and not visualized well by the tumor. There's that port, that tube placed in, we operated through there. The tumor's now been removed, and you see the restoration of those fibers controlling vision. So they were preserved, his vision recovered, and that's an example of minimally invasive through a small opening in the scalp, small opening maybe $half size in the skull, and placing this tube in to work through a very small channel using the natural folds of the brain. We've also have other technologies at our disposal. Here is a fluorescent dye, and this dye is injected and it turns yellow and fluoresces. It emits fluorescence that we can see under a special filter that we utilize under our optics. And the big issue for us is as we get to the peripheral edge of a tumor, if it's a safe area to resect, we worry about, are there still cancer cells left behind that maybe we can't see under white light? So this fluorescence is emerging technology. There are two types. This is the one that we use here to look at the emission by cancer or tumor cells of this fluorescence. The normal cells don't take up this dye. So sort of schematically here again is that tube. When we have something on the surface, it's one thing, but deep within the brain, we go through the natural folds. The lesion is then removed, the tumor is removed, and then as we've already started in the TOCA-5 study, then you can begin to look at injecting certain therapies, chemotherapies, after you remove the lesion. So we think this is currently available, but also emerging technology that's again delivered through a minimally invasive, safe approach. This is the laser system. This is laser brain surgery called laser tumor obliteration. This is the system that we use here, and this is really intriguing. It's an adjunct, or it's an extra treatment that we use for some tumor if it's indicated, and that is the fiber is placed stereotactically or very precision-wise, so a very small opening, about 1/4 of an inch in the scalp, and you see the surgeon at the console, and in the MRI scan, this lesion is targeted. There's the fiber going into the tumor, and then once everything is in position, we turn on the laser, and you can see it here, and you can see the outline of the tumor here, and the heat map is what we follow to see the tumor destroyed. So this is another very exciting, minimally invasive technique. This is usually a one-day stay, an overnight stay in the hospital, and then that little catheter is taken out and one stitch is put in. The patient goes home the next day. So really remarkable miracle surgery in a way that we can do certain things sometimes through very minimal approaches. So I will stop there, and I think we may have some time for discussion or questions and answers. I hope that I impressed you as much as Dr. Merrell did about the tremendous advances in chemotherapy and the resulting clinical trials. And we're working very hard on our side to do a good job to get the tissue out, to make the diagnosis, but also to enable this to be done safely and aggressive surgical removal to allow the patient to do much better by getting the bulk of the tumor out, and that sets it up for the subsequent treatment with chemotherapy or focused or general radiation. So I'll stop there. Thank you for your attention.
Thank you both to Dr. Merrell and Dr. Bailes for your presentation. Right now, Dr. Merrell and Dr. Bailes will take questions. So if you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right hand of your screen. So we'll just do like a brief Q&A session. So let's see. I do have a question here. Phase 4 of the clinical trials wasn't mentioned. Can you please explain a little bit about the phase 4 and what that is?
Yes, this is Dr. Merrell. Phase 4 is often not discussed in neuro-oncology, but it has been recently brought into the discussion arena. Basically, that would be once a drug is approved or a treatment is approved, how do you further expand upon that and modify it in terms of the dosing and the schedule of the treatment. Right now, we're really lacking in FDA-approved treatments. As of last count, and if you include devices, we have a total of 5 FDA-approved treatments or devices. So as we make further progress in the field, there will be more of a need for phase 4 studies.
Thank you. I think you mentioned this a little bit in your presentation, but could you go over what type of questions should a patient/participant ask when considering a clinical trial?
Sure. This is Dr. Merrell. So I think that it's important to ask what the treatment is all about. So we, one of the things that I did not mention is that we have literature that we give to all of our patients about the clinical trials, and that's called a consent form. That is written in language that is not overly medical so that anyone can read and understand the nature of the clinical trial. So we prefer actually that patients would take that home with them and read it, and then come back to sit down with us again and ask specific questions that they may have. That typically generates a number of questions about, what is the schedule of the treatment? Is this a pill form of treatment or is this an intravenous form? How long will I be required to be there for the treatment? What exactly are these side effects, and what are the ones that I would most commonly expect to experience? One of the things about the consent forms is that they often will list kind of percentages of side effects. So, let's say a particular side effect may be seen in roughly 20% of the patients versus another one that may be very rare. And all of these side effects have to be listed just like, they would be for aspirin or any other prescription drug that you may take. But we try to make it understandable so that patients know what to expect, like, what are the most common side effects. The question would be, as I mentioned in my presentation, where is the trial taking place? A lot of these trials open and close, which is another important thing to know is, is the trial currently active? If it's not active, when will it be expected to open again? So those are a few other things that I didn't have in my presentation.
Thank you. Also, this kind of goes along with this last question. What are the patients, what kind of rights do they have during the clinical trial, and are they allowed to leave the clinical trial if they should desire to do so?
Yeah, so that's a very important question, and that we try to emphasize that whenever we talk about clinical trials. So there is absolutely no obligation to stay on the clinical trial at any point in time. We prefer that patients do, but there's all sorts of reasons why you may want to drop out of a clinical trial. Often the most common reason would be that maybe there's an unpleasant side effect that is just too much to handle. But there's absolutely no requirement to stay on a clinical trial at any point in time.
Okay, thank you. This is a question on the surgery for the injecting of the fluorescent dye. Is that a better option instead of an MRI to check if a tumor has returned?
Well, the fluorescent dye is an intraoperative during the surgery adjunct or extra treatment that we sometimes use. We often don't need it, but in certain cases when we think that it's in a safe area where additional tissue could be removed, we will use the fluorescent dye to see if there are any tumor cells hiding in what looks like normal brain tissue. So if it's not an area that we can take a little more out, we wouldn't use it, or if it's already obvious what we're dealing with. So it's sort of for hidden cells. It's an intraoperative drug we inject, and it's different than MRI, which is an imaging study done pre and post-op.
Great, thanks. And do you know if any of the minimally invasive surgery techniques have been used on patients with vestibular schwannomas?
Well, in the sense that minimal exposure, minimal incisions, minimal access, yes, they have, but not the tube going through the small port or tube that I showed. That wouldn't be used for schwannomas of the vestibular nerve. You wouldn't need it in that area.
Thank you. Do you need approval of your surgeon or oncologist to participate in a clinical trial?
I'd have to clarify that question, but if the question is, so if you're, some of our patients will be referred from outside institutions, and they may have had their original surgery by their hometown or local neurosurgeon, and then they may be interested in a clinical trial at our institution. So what we typically do is we like to have a good team approach. So even if someone is not a part of our own institution, say the outside neurosurgeon, we'll have a discussion with them to make sure that they understand the nature of our clinical trial, and if they feel like it's compelling enough for their patient. And it's important that they're agreeable to that. I mean, ultimately, it's the patient's decision to participate in a trial, but I think we like to have all the team involved in the discussion so that everyone is in agreement that this is the right thing for the patient.
Thanks, Dr. Merrell. I think I have time for one more question. If I receive a standard care of treatment, should I be concerned that it will disqualify me from participating in a clinical trial?
That's a good question. So the simple answer to that is no, because if just using glioblastoma again as an example, the standard treatment for glioblastoma is to have fractionated radiation that takes place over 6 weeks' time with daily temozolomide, and then that would be followed by additional monthly cycles of temozolomide. That is the standard treatment, and in fact, if at some point down the line the tumor grows, then the patient in that situation would be very eligible for a clinical trial. Some of the things that can be problematic is if the standard treatment is deviated from. So like, let's say, for example, a patient had some experimental treatment or even an approved treatment that was done at the time of the original surgery. A good example would be carmustine wafers, which are these, it is an FDA-approved treatment, but these wafers are actually often excluded, or they exclude patients from participating in clinical trials. Another example is, let's say a patient had not completed the full 6-week course of radiation. That may be a way of disqualifying the patient. But generally speaking, if you're just having standard treatment, you're very much eligible for clinical trials down the road.
Thank you, Dr. Merrell. Well, that's all the time we have for today for the question and answers. So I want to thank you all again for joining us, and thanks again to Dr. Merrell and Dr. Bailes for their wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line, which is staffed by caring professionals at 800-886-2282. So let's pause for just a moment to conclude our webinar recording.